It's gonna be good. It's gonna be great. It's gonna be better. I can't wait. Making my move. Live for the day. Sing like a bird. Fly like a plane. Come spill with me. Jenny D.
Hello, my beautiful people. Thank you for joining me with another episode of Spill With Me, Jenny D podcast. Today's podcast is brought to you by Clair Health. And my guest today is Amy Danner. And I'm so excited to have her. We're going to be talking about heart failure in conjunction with American Heart Month. Thank you for being here, babe. I
enjoy it. Thank you so much.
Thank you. Would you like to introduce yourself
Sure.
to the listeners and the viewers?
So my name is Amy Sims Danner. I am an acute care nurse practitioner and specifically in heart failure at Clair Hospital. I've been a nurse practitioner for about 20 plus years. I started in cardiology at first. I'm not doing specifically in heart failure, but general cardiology. And then I moved to internal medicine with the hospitalist group here for 11 years. And then when Dr. Prey, who is the heart failure specialist here, approached me to start a heart failure program here at Clair Hospital, I was absolutely thrilled because that's my main focus, even through school,
Right.
To do heart failure. So I started the program with him, and it's been a great 3 to 4 years, and I'm so happy to talk about it today.
Oh, I'm so glad you're here to talk about it because I always say this, I don't feel like we talk about heart disease enough. And especially with women, this is a number one killer for women. It's 1 out of 3.
Right.
U.S. die every year.
Right.
So this has been going on for 3 years. So let's get into some of these questions I really wanted to ask you. See, like many people, they hear like heart failure and they assume it means your heart stops working completely. Can you explain what heart failure actually is?
Okay, so back in 2022, the American Heart Association and the American College of Cardiology and the Heart Failure Society of America stated that heart failure term was a complex clinical syndrome with symptoms and signs that resulted from any structural or functional impairment of the ventricular filling and or ejection of the blood from the heart. As I explained it to my patients, I said that the signs of volume or sort of like fluid in your body, no matter if it's low extremity edema, no matter if it's shortness of breath, no matter if you're lying down and you're getting short of breath lying down or you're short of breath have to sit up. Right. This is all deal with from the right side of the heart to push the blood into the lungs or from the left side of the heart to push the blood to the rest of the body. So basically it's a term of just volume in your body. Not so much that the heart is failing, but there's a lot of etiology that could pertain to that to get you this fluid overload in your body.
Okay. Oh my. See, outside all those terms, I was like, oh,
yes. Yes.
Are there any other misconceptions about heart failure that you'd like to clear up today? I know there's so many, like you just, for me, I feel like when I think about heart disease, I think about you have to be older or, you have to be a smoker or,
Well, there's a lot of things that come in with heart failure is that a lot of people that have uncontrolled hypertension, the blood pressure is not well controlled, they're obese, they smoke, they drink alcohol, they have structural heart disease, they have kind of lung disease. There's a lot of things that go into the etiology of heart failure in order to build what is called this congestion or fluid buildup in your body.
Right.
But most of the modalities that we give them will help control those symptoms.
Right.
And hopefully help their heart function better to make them live the most quality of life.
Perfect. Thank you. Are there specific groups who need to be aware of heart failure risks?
Yeah. So again, the AHA and the American College of Cardiology have stages of heart failure, which at the stage age is more population that are at risk, including people with high blood pressure, people with type 2 diabetes or insulin diabetes, people with obesity, sleep apnea, atherosclerotic cardiovascular disease, including heart attacks, coronary disease, people with cardiomyopathy, illicit drug use, sarcoidosis, amyloidosis, as well as just smoking can cause you at risk as well.
Yeah, when you do hear about someone who does have like a heart attack,
Right.
and they are in great shape, I'm always like, well, how did that happen? Like, it's always one of those things where you're
But
like,
that has a lot to do with their health lifestyles. I mean, if they're smoking, if they have family history, if they have diabetes or high blood pressure that's not well controlled, then they're at a higher risk. It's the same thing with heart failure too. So the stage A people are just at risk, so they don't really need a lot of medications to control volume in their body, but they have to control their other modalities, their other health risks. Their hypertension has to be controlled, their diabetes have to be controlled, their lung disease has to be controlled. So all this stuff has to be controlled. But then you get into stage B, which is pre-heart failure, which it actually includes like valvular heart disease and then potential of congestion with fluid in your body. And then you obtain what's called a transthoracic echocardiogram, and then you're looking at the heart, you're looking at the filling of the heart, you're looking at the chambers of the heart, you're looking at the valves of the heart. If you have any abnormalities of the valves, but not causing real true congestion yet, then you're at stage B.
okay.
When you get to stage C, then you have the risk of A and B plus the congestion and plus other issues, the congestion, the weakening of the heart muscle, the valve getting more stiff or leaking more. And then at that point of time, you're starting to be admitted for a congested heart failure. And then we do the medication modalities at that point.
Okay, because I was going to say, I didn't even know there was all that. I mean,
there's all different stages, and then you get to stage D, which actually is like end stage of heart failure. And basically, you're looking at, we've tried all the medical modalities, we tried the devices, we tried everything to get his heart stronger, to make him live a quality of life, but he's just failing in that sort of situation. And then you're looking more towards palliative care at that point.
Okay.
Yeah.
So, like, what are the early warning signs that people should look for? I mean, do you think that is it that obvious? Sometimes I was just talking to you about this off air, Amy, that, I was feeling like, when I had the flu, I was like, oh my gosh, I can't breathe. I can't, I have pain in my left arm. Oh
right.
I'm starting to feel like, is my jaw hurt? You start thinking those ones that everybody says,
right?
Those symptoms,
right?
What are the earlier ones?
So basically, when we see patients that come into the emergency room, they're short of breath with even minimal exertion. They're even short of breath at rest. They can't lay flat at bed because they're so dyspneic. They're so short of breath when they lay down. They have to sit up. Their legs are swollen. Their belly swollen. All this other, which constitutes fluid in your body.
Oh.
Yeah. So those are the big symptoms that we get when people come in with stage C heart failure, because they have all these symptoms and, and it could be for different etiologies. Either the blood pressure is not controlled, their heart muscles weakened, they're in a regular heartbeat, and it's going fast. So it's hard to say. But when you start to get these symptoms, then you're having what's called congestion or fluid overload. And that's what brings you in, and we give you medication to release the fluid. And then we do, different type of imaging to see what's the cause of the fluid overload.
Okay, right. Now, how important is early diagnosis and intervention? What difference can it make for patients' prognosis?
Okay, so the biggest thing that they say to do for early diagnosis is, to see your primary care physician at least once a year to do a very good history and physical, and also do a really good family history, because a lot of people have big, strong family history of heart disease. They have sudden cardiac death in their family. If they've had family members that have pacemakers, ICDs, defibrillators, or if they've died in sudden cardiac death, heart transplant, anything like that, or have had heart failure, then that patient's still at risk. So the most important thing is to have a good history and physical and a family history in order to bring in early signs as well as a good physical.
Let me ask you this, Amy. If I came into the doctor's office, and would I have to ask for like an EKG or?
So we normally don't do an EKG unless you're feeling symptoms. I mean, EKG is, we usually do it with chest pain, or you're short of breath, or you're having palpitations. Stuff like that will prompt you to have an EKG, or you have a family history of heart disease. Many you're above the postmenopausal age.
Oh, yeah.
Or you're, or you're,
I hate that one.
yeah, I know. And it's true. It's women's estrogen helps them until they're postmenopausal.
Right.
And men don't have that. So there are heart diseases earlier in life. But we normally don't do an EKG unless you're having symptoms.
I know, because sometimes, I just talked to someone over the weekend and they said they went to the hospital. They thought they were having a heart attack. Well, here they ended up having a panic attack.
Right.
So I don't know what the difference is, but either one, you need to go to the hospital right away.
Yes.
Because those are kind of like the same. You can't breathe. Your heart rate's really up.
Yeah.
Yeah. Now, what role do medication, lifestyle changes, procedures like implantable devices play in managing your heart failure?
Okay, so once you're diagnosed with heart failure, and basically, when you come in to the emergency room and you're in heart failure, basically we do, typical labs, CBC, CMP, TSH. We do anemia workup in case you're anemic, because that could cause shortness of breath. We do different type of testing to see if you have fluid in your body called a BMP. We do EKGs, chest x-ray. And then what we do is we give you diuretics, like Lasix or bumetanide, in order to decrease the fluid overload or the congestion. So basically what they do is they take the fluid from your body and put it in your blood system and release, you urinate it out. So basically it goes through your kidneys and you urinate all that fluid out.
Okay, so that's how you can get rid of that.
That's how you get rid of the congestion of the fluid.
Okay.
And then what we do is we do what's called an echocardiogram, which is a transthoracic echocardiogram, in order to see what's the cause of this fluid overload. Is it a valve that's leaking? Is it a valve that's stiff? Is your heart not pumping well enough, called cardiomyopathy? Or you're in a irregular heartbeat that's causing the heart not to work properly? And then what we do is we add different medication depending on what type of heart failure you have. Okay, so there's two main heart failures that we based our...
Two of them? Okay.
There's two that we based our medications on. One is called heart failure which reduced ejection fraction, which the ejection fraction is the left side of your heart that pumps the blood to the rest of your body, which is the left ventricular. And that's in our ejection fraction normally pushes about 60% of our blood to the rest of our body.
Okay.
If you're below 40%, that's a reduced ejection fraction of heart failure.
Oh, really? Okay.
So there's four main medications that we put people on to help their heart muscle improve.
I'm like, oh, I'm going to write this down.
So one is called an SGLT2, which you've seen on TV. Those people also take it for diabetes, but we use a smaller dose to help your heart function better, which is Farxiga and Jardiance. So that's the first medication we put you on. The second medication we put you on, it was called...
And how long do you put them on?
They're on forever.
Okay.
Even if we give them these four medications and their EF improves, that tells us that those medications are working. So they need to continue on those medications to keep their heart functioning.
Okay, so you give them like a week on that medication then?
Well, we give them and let me go over the medications first, and then we'll go there. Okay, so the second medication we put them on is called Entresto, and that's an angiotensin receptor blocker, nephrosilin inhibitor, and that's a medication that will actually help your blood pressure and help your heart function better to improve your ejection fraction to the blood to come out of your body. The other medication is called a mineral retentive angio blocker, which is called spironolactone. And then the fourth one are the beta blockers, which we use is like metoprolol and carvedilol. Now, those are the four main medications we put you on to help your heart function better, to increase your ejection fraction, to make the heart pump the blood out to the rest of the body, to your organs, to your brain, just to help improve. And once you're on those, in about 3 months, repeat your echocardiogram.
Okay.
We'll repeat to the echocardiogram to see if you have any improvement. If there's improvement, then you stay on those four medications. But unfortunately, heart failure, just like any other cardiac disease process, it can come and go. So you can develop congestion, you can develop fluid, no matter if you're on these medications. So we use the diuretics periodically to help with the fluid overload, but it's not a main medication to help your heart to improve.
Right, because it's not just the medication. You got to change your diet.
Well, we'll go over that with the diet and the exercise and stuff like that. So in about 3 months, if your heart doesn't improve and you're still below, 35% and you're not improving either, if you've gone through a heart cath and opened your heart artery to make the heart muscle improve, we do have devices to help your heart kind of contract together. One is called a CRT-P, which is a biventricular pacemaker, which we stick a lead into the right ventricle, and then we stick another lead into the left ventricle, and we make them pace together. So that's why you have synchrony of your heart. That way it will pump better with the left and the right communicating with each
Who
other.
invents these things?
I know.
I want to know this. I'll tell you what, they're pretty smart.
Right. And then when your EF is below that and it's 35, you're at risk for what's called sudden cardiac death. Then we also can stick another lead into the right ventricle, which has a little defibrillator device in it that will shock your heart if you go into a life-threatening arrhythmia.
Okay.
So that's the only reason we use those devices, for those reasons. So the other heart failure is heart failure preserved ejection fraction, which means that your ejection fraction is above 40%, and it's for other reasons like high blood pressure, or is it because you're in a irregular heartbeat called atrial fibrillation? Is it from coronary disease? Is it from valvular disease? But your heart muscle isn't weakened. And those pretty much, we use, the SGLT2s to help with the fluid overload. We use the spironolactones, the MRAs. We also use like ACE inhibitors to help your blood pressure, and the angiotensin blockers. We really use a beta blocker unless you're having problems controlling your heart rate in the atrial fibrillation. That's the only reason we use the beta blockers.
Okay.
And then, from that point, you're looking at a good diet, including 2-gram sodium diet. If you're diabetic, you use the ADA diet as well. We ask them to drink when they're thirsty, not to force fluids, because you're just putting more fluid in and we're trying to take it out. So we put you on like a 2-liter fluid restriction. As far as exercise, when you come back, we try to enroll them in cardiac rehab to help them with their exercise, but we pretty much tell them just to stay physical as possible. Go off a little walk, or if you're able to walk around the home or whatever, just stay physically active as possible.
Right. So that's when I was going to ask you that.
Yeah.
The good quality of life is maintaining a little bit of everything.
Yes.
The diet,
the exercise. And the biggest thing we ask our patients to do when they go home is to weigh themselves every day. So they get up in the morning, they urinate, they step on the scale, and then they weigh themselves.
Okay.
If they notice that their weight's going up like 3 pounds per day or 5 pounds in a week, then we know they're starting to reaccumulate fluid. So we know we either have to put them back on the diuretic, which is, to get the fluid out, or do we have to adjust the diuretic to make their heart function better? Because our biggest problem is we don't want to have them come back to the hospital.
Right.
In congested heart failure again.
Yeah, because, that's the thing. It's like when we were talking about that, and you use so many big words.
Yes.
I was like, I got to get my dictionary out. What is that, the thesaurus?
Yes.
Is there such thing?
Yes. So, we have a lot of education.
You do.
We have a lot of education in the hospital, and I do most of that. And then when you leave, you have a week follow-up with our physician assistant, Melanie, who is in our heart failure clinic, and she will go over your medications again. You'll get weighed, you get your blood pressure, and she'll go over a little bit more education as well. We also have a pharmacist as our outpatient clinic, so she can go over the medications too. So people
Here
get
at the
confused.
hospital, St. Clair Health.
Yeah, so she rounds with me during the morning, and then she goes over to the clinic on Tuesdays and Thursday to help Melanie out to educate the patients out there as well.
Are you finding what age group would you say that is more, and men or women, are you finding that there's more like people in the 40s to 50s, or, because I'm hearing about somebody 50 years old have.
Well, usually with heart failure, it's usually people with over 65 to 95, depending on, most people that have, uncontrolled hypertension, diabetes, obesity, but basically with structural coronary disease or heart valve problems in their elderly ages and have multiple modalities on those. And then all of a sudden their heart gets weak or very stiff and have other, medical problems that we need to address. But usually we don't see it below that.
Below that. Okay.
No. I mean, sometimes we see it in obesity if they're, in their late 50s and 60s and they have sleep apnea and they're not on like a pressure controlled mask at night, then the heart gets very stiff on the right side and then they develop low extremity edema and abdominal bloating. And then we kind of have to kind of fix that as well. There's a lot of components in heart failure.
There's a lot of
components that you have to look at.
I cannot.
Yeah, it's not specifically on just your coronary disease. No. It's not specific just on your heart valve. It's so many different different type of past medical issues that need to be controlled in order to keep your heart functioning well so you don't develop any congestion or
Well, you're in good hands here at St. Clair Health when you have Amy here, because I'll tell you what, all the things that you've said, I'm just like, what?
It's a lot to handle at one time. And you get people that come in and are like, well, this is my first time having this. The first thing we had to figure out was why you're having it. And then we can kind of discuss why you have it, what medications you need. And then it's a continual education every day until the discharge. From admission to discharge, it's a continual education every day.
Oh, and I love it. I love that, you're here and that you have all the knowledge and you can help so many people.
Yes.
I mean, do you have any advice or words of wisdom for patients or loved ones who are navigating like heart failure diagnosis?
Yeah. So that's, we try to integrate our patients' families in our discussions when the patient's here. Yeah. And we ask, we either call them on the phone or they're usually here and we have the discussion with the family, with the patient. But also in our clinic, when the family brings the patient to the office, we have another educational kind of modality with our outpatient clinic as well. So it's a continual heart failure education all the time.
Right. And we, as a public and the listeners, my audience, like we need to be aware of the signs and educate ourselves every day, because there's times where you forget. You're not thinking about it or you're doing something. I was doing a spin class today and I felt myself like, oh my gosh, I'm so, exertion and so out of breath. And I thought, all right, that has nothing to do with, but you just worry. You become like so worried about all the things that you could.
Well, basically, as long as the patient's taking his medications, he's eating the proper diet, he's exercising the best he can, he's weighing himself every day, he should be pretty well controlled. But there are periods that all of a sudden his weight goes up or, he went out with his family, ate out, and salt, you can't control salt all the time. Then all of a sudden, 2 or 3 days later, their weight's up a little bit. And that's what they kind of need to know is like, okay, I'm going to trigger it now. I'm 3 pounds up. I'm going to call the heart failure clinic and then they can increase my Lasix for, my diuretic for 3 days. And then all of a sudden I don't have to come to the hospital because I've already taken that water off.
Right.
So they just have to get in tune with their own body. Everybody has a different way to adjust to their own body.
I always say that you have to be an advocate for yourself.
You do.
If you're not, you're the one that's going to fail at it. Because if you don't get yourself checked, and that's the other thing, when we were talking about primary care, we were talking about getting checked once a year for at least getting yourself, getting your physical, because you just don't know. And sometimes you find that with heart failure, maybe it's not hereditary. Maybe it's just something that, you're born with or.
Right.
Yeah.
Well, it's usually due to a disease process. It's not genetic unless you have a specific type of what's called amyloidosis could be genetic. And that is a restrictive heart disease and usually it's usually genetic from family. So if your family's had sudden cardiac death or amyloidosis, then you need to be checked sooner. But we usually don't find that out until we find a patient with amyloid, and all of a sudden, we do genetic testing as an outpatient, and then we have their family tested.
Okay. Yeah. Because I think
that's a different disease process than strictly just heart failure. It can cause heart failure, but that's a different disease process.
Right. Yes. Now, is there anything else you would like to talk to the audience or listeners about that we didn't cover today?
No, I think we're all good. And, if you're come in with heart failure, you'll see me in the hospital, and then we'll get you all clicked up in our heart failure clinic.
I so appreciate your time today.
I had such a great time.
I know. And I just thank you, St. Clair Health, for just educating the public, the community, our listeners, because this is something that, it's February, it's American Heart Month.
Right.
And we need to be talking about this.
Right.
And we just have to be advocates for each other.
Mm-hmm.
You have to talk to your friends, your family, and say, hey, listen, have you got checked? Just get checked. You just never know.
Right.
You never know when it's going to happen. So I thank you so much for being on.
Well, thank you for having me. It was so nice to meet you.
Nice to meet you too.
Yes.
Thanks for being on Spill with Me, Jenny. Yay! Take care.
Come spill